And we have Elizabeth, who will take it as a health advocate and tell us a little bit about her experience with the triple. But before we do that, it's important that we just say our name wherever we are, so that our two speakers know us. Just say your name, perhaps your country, or what your media house, and that will be it. So could somebody help me very fast to go around with the mic? Miriam, please start it off.
Good morning. My name is Miriam.
My name is Godfrey Obogo. I edit science.
I'm doing what focus with. There is here in town. I report for Radio Kenya Nairobi and Africa.
For Science Africa.
I'm Robert Malala, Nyota TV, Western Kenya. So the Independent Population Publications, Malawi.
Rosemary Shari Capital Account.
Della Wilson from the University of Nairobi and also service.
I'm Stella Siko, a journalist with the Herald in Zimbabwe.
And Christopher Itaezo from Rwanda, publication called Nana.
I'm Shepalevsky from PCL. Aggie Lavenda from from
Truly Modesty, correspondent for Down Earth Magazine.
Maina Waro, from journalist.
Please for the home, freelance.
TV correspondent, Kenya.
I'm Steve Mokai from the Standard Group. I'm the program producer.
I'm Silvio Sono, Nation Media Group, Nation Kenya Nairobi.
Morning, everyone. My name is Makoto. I'm the freelance journalist, climate change and environment based in Southwest.
My name is Mary Walker, and I'm a Malawian journalist. Please change it and Helen Gisega, multimedia journalist from Kenya. Thank you.
Hi everyone. Elizabeth Dida, I am an advocate, women's rights advocate, and I work in the organization called the Gender Everyone. Thank you.
Hey, I'm Rita Tuano from Pakistan, Tanzania, working for East Africa.
My name is Violet Neko. I work with the Gender Daily now.
My name is Manuel Lele from Kenya, working with studies.
I am Richard Mapatra. I work as the technical power publishment.
I am Suganya. I am the Center for Science and Environment Unit.
Yeah.
My name is Vincent Yusu, journalist with the Media Trust Group based in Abuja, Nigeria.
Right. And my name is Agan Daniel. I'm the Secretary and CEO of Media for Environment, Science and Agriculture. So
my name is Agatha.
could you get the mic, please?
I'm Agatha Ngogo. I write for the Standard.
Thank you. We are pleased to be on our 101 media cafe. We are going to have another one in the afternoon, and the afternoon one is going to be totally different. We are going to talk about issues of pandemic preparedness in Africa, and we are also going to look at issues of vaccination. So those different things all together. So for now, we want to talk about the triple threat, and I welcome our first speaker. She's basically going to give an overview in terms of the science. Please feel free. A science cafe is not a workshop. Feel free to raise your hand at any time within the presentation. Don't let the speaker speak throughout, okay? Make it as interactive as possible. I want to sit back there because it's a different session. Caroline will talk about where she works and who she is, and then delve into a short presentation. Caroline, karibu sana. Karibu sana. Sorry that she's still the executive of the presentation, that you're not able to join us at that time. But this is the public group. They have been meeting for the last 3 days on various issues. But now it's time to talk about health. Karibu sana. Enjoy yourself.
Good morning, everyone. My name is Caroline Kinoti from National Syndemic Diseases Control Council, former National AIDS Control Council. It's a government agency that is charged with coordinating the HIV response in this country. So I'll take you through a presentation on the triple threat, and then in the process, I'll explain what the triple threat is. But before I start, let me say it's my honor to be here today to interact with you, share our perspective on issues of HIV response. And it's the first time I'm interacting with very many journalists. So if I don't know how to go about it, but I'll do it how I think I should do it, okay? Yeah, feel free, ask questions, and let it be as interactive as possible. So I'll talk about the triple threat and explain what it is, but before that, I'll talk about the HIV program. And I'll start by talking about where we are at and look at where we are coming from. So I'll share data from 2010, and at that point in Kenya, and the data is, the perspective is Kenya. So for the journalists outside Kenya, maybe you can try and relate this to what is happening in your individual countries. So in 2010, where my story begins, we had a HIV prevalence of 6.4%, whereby mother-to-child transmission rate then was 21%, and we had 1.4 million people living with HIV in Kenya, and an annual new HIV infections of 71,000 people newly infected with HIV in 2010. So that's the background where I start laying a basis of where we are coming from and where we are at. The figures were high, but this was a great improvement from where we were coming from in the early 2000s. And I'm happy that Dan talked about a meeting you had with the late Invionata on aspects of HIV and her journey as a HIV positive person. By 2010, we already had ARVs in the country. So the number of new infections had started coming down from an initially higher figure of over 100,000 new HIV infections per year, and even more people dying. But by then, still the numbers were high, at around 53,000 deaths in a year. Now, we've shown the data progressively from then, but allow me to focus on 2022. That is the latest data we have. whereby we have a prevalence of 3.7% of the Kenyan population living with HIV, 18,000 deaths that occurred in a year as a result of AIDS-related aspects. We say AIDS-related deaths. Mother-to-child transmission rate, MTCT, still very high for our country at 8.6%, meaning that for women who are HIV positive and are pregnant, 8.6% of them pass the HIV infection to their babies, either through delivery or during the breastfeeding period. And we had a total of 22,000 new HIV infections in the year 2022. As much as we are talking of progress, remember these are individuals. The statistics translate to people. And when a person is infected with HIV, their life changes because they have to start on antiretroviral therapy for them to live a productive life. Also, there is no cure. So you live with the condition, and our hope is that when the person will live to enjoy their full life. But the rates are still high because our hope and our goal as a country is to ensure that we end AIDS as a global threat by the year 2030. And the government is keen to have us even bring this closer and end it as a global threat by the year 2027. Whereby, for us to do that, it means that no child should be born with HIV, and it's possible. So moving forward, this is now our current data as a country. I've just brought out what I presented to this, showing that we have a prevalence of 3.7%, has come down. And we know it can't be zero because it means if it comes to zero, there's a problem. It means that all people living with HIV have died. We don't want to get to that point. We want them to live their productive lives, but we don't want other people getting really infected. Then something of interest here, something we'll now focus on more closely, is that we find that there are more women who are living with HIV than men at 5.3% in comparison to 2.6% of the men. So the gender aspect starts coming up from this point. And then we find that among the adult new HIV infections, and for adults in health, this is the age group from 15 years plus. We find that adult new HIV infections occurred among, there were 41% new adult HIV infections among adolescents and young people aged 15 to 24 years. So that age group from 15 to 24 years, we had even more adolescent girls and young women getting newly infected. Looking at the different counties, the county perspective, because the 3.7% is the national aggregate. But we find that there are counties where the prevalence is high. That is along the Lake region, Homa Bay, Kisumu, Migori, Siaya, Busia. That's where we have more people living with HIV. Then we have also Mombasa, it's a city. We have Kisii, we have Samburu. Samburu is where we are finding new HIV infections coming up. Adolescent pregnancies are on the increase. And I know that was featured in also the Kenya Demographic Health Survey, Vihiga and Uasin Gishu. Uasin Gishu is the latest city we have in the country, and their prevalence is quite high. This does not mean that other counties are doing well, only that they are ranked, and these are the counties with the highest prevalence or the number of people living with HIV. Yes.
Kisumu, Homa Bay, and Mombasa. This is the right. Okay, so why do we have this high rates in those places? Because my teaching knowledge of Mombasa is also a big city. So why do we have such a low rate in Mombasa? And places like Homa Bay, we are having 15.2%. What are the factors? What are the issues? Why do we have this thing?
Yeah, and by the way, Vincent, 4.8 is not very low.
Yeah, no, but when you compare, I'm comparing what you have in the data. Not, I'm not saying that it's very low. But if you look at the data, they are not. I just want to know why do we have 14.5 in Kisumu and we are having 4.8 in Mombasa? And these are very big cities.
And 15.2 in Homa Bay.
Yeah, so
where you will think the people are.
yeah.
People are.
Yeah, it's not a very busy place, without reflecting on you again.
Yeah. How can they explain? Okay, you see, Nairobi is even good there.
Yeah, Nairobi.
Yeah, it's just that, Caroline, one of the problems that we have when it comes to HIV is something that we call stigma. And I just want to report to you that the ladies seated with me on this table are really stigmatizing me because I come from home.
I will address that.
Yes, go on.
I just wanted to know the population size of Homa Bay, visas, the other. These are seated, counted, okay, counted, yeah, okay, so, I just want to know the population and what can be the contributing factor? Is it cultural? Are they tourism destinations? What so much, I mean, what are the other defining factors that may have contributed to them topping the list when it comes to the Bay population?
Okay, now let me explain.
Okay, in addition to that, you talked about women living with HIV are higher than men.
How does that?
Yeah.
How is that? Okay, fine. So let me explain. Homa Bay, Kisumu, Siaya, Migori, culture has a big role to play in that. And you find that that's where we had issues of wife inheritance taking place. If somebody died, somebody would inherit the wife. There is the issue of sex for fish along the lake. So culture has a key role to play on the high HIV prevalence in that. Mombasa is a city. So Mombasa, you again look at the setup. It's a tourist destination, as somebody said. We have issues of substance and drug use, injecting drug users, sex work, and that is also cropping up in some of these counties like Uasin Gishu. Something else we are seeing is that for some counties that were initially, traditional, their cultures, as somebody said, they are more closed out. Now, with better mobility of people to different counties, different places, then that also has contributed to new HIV infections. So for the counties, the upper counties, culture has a big role to play in that. Then Mombasa, as I've said, Uasin Gishu, those are upcoming cities. And now mobility of people, that they are opening up some of these communities. There was a, yes, ma'am.
My question is, I wanted to know, just looking at Homa Bay, Kisumu, and Siaya, we know that those areas, there is that high prevalence of sickle cell anemia. So now I'm wondering about the rate of infection and also looking at the culture. So how does sickle cell anemia affect them, and especially when it comes to the intake of ARVs and also the mortality rate?
So what you find is that for HIV, if your immunity is compromised, then you are at a risk of even progressing very fast to AIDS. And remember, not all sexual acts with a person living with HIV lead to HIV. Not everyone gets infected. It depends on the viral load level of the infected person. If they are very low viral load, then the chance of transmission is low. If the immunity is compromised, as you're saying, then the chances of also getting HIV and also transmitting is higher. So there's that link, and I believe that's also something you can follow up and see if there are studies that have linked that even more. And it would be nice to have that. Yes?
From the illustration, I can see the top 5 counties have got one thing in common. They all share the thing. Maybe talk about it. Does it have anything to do with it?
Wow, yeah, interesting. Because even, they share the link, but the water has nothing to do with HIV. Yes? HIV transmitted through a virus, but the aspect of now fish for sex comes in, yeah? Whereby we have now, well, that there are those who go to catch the fish. There are traditions that come with that, in that maybe somebody from the community can guide us and tell us, but what we've read and seen, you want to explain that? Okay, such that you find that before they go to catch the fish, they must have sex, yeah? There are also women around there, the fishmongers, because there are those who go catch the fish and they bring, there are women waiting, and sometimes to get the fish, you have to align yourself to one of the fishmongers. Sex is sex involved, transactional sex for that. So it has nothing to do with the water, but the behavior that happens in the process of selling the fish, getting the fish. Yes.
No, I wanted to sort of, I don't come from that area, but I have an idea of what happens there. Yeah, as in, traditionally fishing, it's, they go deeper into the lake, right? And mostly it's men who do that, men and young men. So women, and I think there's some culture of prohibition, women are not allowed to go with them. No? They do it at night, very early in the morning. So women only wait for the fish that has been trapped and brought on the shore. So there's normally that situation whereby they have to rely on these men, and so they are supposed to buy this fish. But now when you have maybe a connection, a relationship with some of those guys, you'll be given maybe the fish of credit, or that kind of thing. Yeah, so basically I think the whole idea that women are not allowed to go, and it's also a very risky thing for women. Yeah, so they rely on those guys who go there. Most of those guys, basically that's the explanation.
There's another question.
I come from Hama behind us. It's very the fish is not bad practice, big practice. People who are either horny or sexually starved or whatever, and they find any it's not our culture. But my question is, we've always been told that more women are contacted compared to men. But there's this discussion that's also coming up that we need to be that more women go for tests compared to men. Because men naturally don't go to hospitals. They rarely go to hospitals. But women will go to hospitals for so many reasons. Big gynecological issues, to give birth, if you have like, let's say, your first birth, you will be tested for HIV and all that. So, and I tend to believe that there might be many other factors, but I also think so many women go to hospitals more frequently compared to men. And also in a case where a woman has been tested and she's been found to be positive, and she's a married woman, even when she goes home and tells the husband that you're supposed to go and be tested together, that man will not go. Most of them refuse. Even and at times it's even the husband who infected the wife and he knows he had it, but he will not admit it and he will go for testing. Yet that statistic will be lost along the way, but the woman will be more open because her condition has already been known and she has taken care of it and showed to us to go through the mother's children program.
Okay, so let me first explain that. I know somebody had asked also about the issue about more women being infected more than men. Let me say it's not just because more women go for testing, that's true. But the data I am sharing also it's from estimates, and it shows there are more women than men who are infected with HIV. And because of the biological nature of women, the surface area and possibility of getting infected when a woman has unprotected sex with a man is higher because of the larger surface area, yes? So that way you find then more women get infected. And I said, it's not all sexual acts lead to infection. So biologically, women are more affected. And also, we find that it's true, more women seek health services. Because naturally, yes, when they are expectant, when they are when men rarely go to seek health services, but that does not mean then there are more men infected, only that we don't know. That's what I want to correct. Still, more women are infected than men.
So, can I ask the question?
Yes.
I have two questions. When we report, especially the top 5 counties, that one of the contributing factors to why HIV prevalence is high in those regions is because of the sex for fish. And we also kind of stigmatize these people there in a way that even some marriages can break because of that. If someone just says, my mom sells fish, so chances are my mom always has sex so that she gets to bring home or to sell. Please explain that so that we also understand how we're reporting it. And then the other thing, in those regions, is the government giving the free condom like it's given in the public universities and other dispensaries?
So that was just one example. I didn't say that's the only cause. Yes?
Yeah, but I think on the same, I was also getting worried in terms of the approach to a story. I know you're presenting the data, but I think most of us are thinking stories. What she's raising is very, very important. So one day, there was a story that we did, I think, about members of parliament. So an NGO said we are supplying condoms to members of parliament. And I think we reported a figure, like this number of condoms, you know. So the condoms that the NGO had provided that day probably could have been in thousands. So they have all, you know, been taken from wherever they were put at parliament. And parliament was really mad. You know, the MPs were saying, the portrayal in your article means like when you come here, we are picking condoms, even when, you know, we are very responsible people. So how best, I don't know, maybe the answer should not come from you, but maybe other experts in this room, how best do we tell this story about sex for fish? And also we should be aware that, we always think of a woman as a victim in this case. So a woman goes there, she needs fish, and therefore she volunteers to have sex. But we must also be gender sensitive to think about the man himself. I mean, who goes fishing for hours only to have sex for the fish that he should have sought. Thank you so much.
And let me say, I don't have one answer. You have even the answers yourself, isn't it? And some of the stories. And thank you for saying that. For me, I'm doing a presentation on what we have. Then you are thinking about that story. I guess I'll try to, as I'm presenting, to think about that. I should have prepared. Then you should have prepared me.
The point I want to raise that I'm from Ignorant and I'm a law. So we sometimes when the figures come, I can joke about figures. I don't think we
yes,
like on the issue of sex fish, not even competition. Yeah. And then counter agreement are not allowed to do it, even our taboos. But then when I look at my community, we tend to be a little bit liberal about sex. Before even HIV came, a lot of kind of things like that. If I'm a man, I want to start our own sex, I want to sleep with the wife. If I want to take my land, I have to sleep with the land. When you want to remove the clothes, there's a lot of things. People are liberal about sex. And we have noticed that this being liberal has made people to be very comfortable about taking it. We are also very liberal about taking ARVs. In fact, some of the politicians, even in rallies, they call it out. And this being liberal, sometimes, people, we have been trying to fight things. When HIV came to Kenya, while other communities were trying to fight, with us really, people nowadays really illegal to test, their status. You are in the home, your mom is HIV positive, your sister, she's taking the ARVs. So we are a little bit liberal. And sometimes I think this being liberal is why people can easily test. And then if you look at the figures, I'm thinking, because the top 4 counties, like Kusia, the area. So you find that when NGOs are financing, they finance a lot in the area. You find that, for example, one facility cannot even find NGOs in that community. So if I'm HIV positive, I can be tested by 5 people from different organizations. So this data, you not been thinking about this data. Like I'm not person tested me and positive. So the number can be going higher. I've been thinking, so and then on the issue of mitigation, like on the issue of sex, it's not their hands. Because one, most women nowadays own women own cages. Women too, they own other activities. And women are even apart from the fishermen, they're like now the men are good fishermen. So it has not been there. Sometimes I think, because my wife also works in the sector, and sometimes they have pressures because I am financed here, I'm in GOA. So when you're doing a report, you have to give it. So I've been HIV positive for the last 13 years. And then for the last 13 years, my friends, I have not been infecting anybody. But then you are near NGO which is coming here, and then your donor has told you, give me the figure. Sometimes even the evening, when those clerks are entering that, you are fatigued, everybody knows you cannot get me. Then you are trying to look for the infection. So sometimes those figures. Okay, that's
a concern the citizen opposing factors.
Let me moderate the session. This is the captain speaking. This is the captain speaking. This is the captain speaking. So I think what we do, give you the next 10 minutes to go through the slides, and then we'll open it to the plenary. With all due respect, I respect your views. I respect the vibrance of the session, but I will just continue Carol, don't feel like you've been thrown into a den. And if you are thrown in the den, you are with the den yourself.
But I have a question, okay?
No, after Carol finishes.
Just hold the microphone.
Oh, okay.
Thank you, Daniel. I needed that. Remember my disclaimer. Yeah, I came here to present data. I didn't think about the stories that you are here to capture. I'll quickly go through the slides, but let me say that the data I am presenting is based on estimates. We have a model that we use to get the data. So what you're saying that sometimes people are under pressure to add numbers to, you know, somebody can be newly HIV infected every year, that is not part of what I'm presenting. It's based on the model. And the aspect of culture, it's broad. You have explained it very well. Yeah, it's broad and how that leads to new HIV infections. Cover it broadly. Don't be very specific that it's only physical sex. I like what you said about liberal, about having sex during several events and all that. Yeah, maybe that's not my story. So back to my presentation, we found that, well, for sexual and age, for HIV epidemic, that there are different drivers and differences across different age groups. For instance, for girls between the ages of 15 to 24, they are 4 times more likely to get HIV infection more than young men. Maybe that's something you can now find out why. Then also for geography, looking at the Kenyan map, there are places, and that was shown from my earlier slide, whereby there are high rates of HIV prevalence along the lake region in some of the counties, and it's low in other counties, especially the northeastern counties, with 0.1% in Garissa and Wajir. So the differences in counties and geographies. And then populations. Different populations have higher rates of HIV infections, and this is also based on behavior. For instance, we have sex workers, truck drivers, men who have sex with men, members of the fishing communities, prisoners, and people who inject drug use. This is based on the nature of their work. You find that there are higher rates of new HIV infections than the general population. And maybe it's also to find out in some of the pockets, where are we getting new HIV infections? And I'll address that as we move forward here. From the data we had for 2020, whereby we found that from the general population, the prevalence was 4.3%, as you can see, that was 2020. But like for people who inject drugs, because they share needles, and other than just sharing needles, sometimes they have sex and protected sex, so the rate of infection is higher, and for that population, it was 18.7%. Men who have sex with men also, it was high at 18.2%, and for female sex workers, 29.3%. So when we are now focusing on interventions or even activities, then we can't ignore these groups, because we find that their rates of infections are high, and they also interact with the general population. It's not that they are just closed, because, for instance, who are the clients of sex workers? Yes? Married men, they are safe. It's like everyone, isn't it? So if we don't tackle their infections, then we'll have even infections going up across the general population. This is also something very important about mother-to-child transmission of HIV. And I know we can address this Because if a HIV positive mother takes ARVs, delivers in a facility, yes, then the likelihood of giving birth to a HIV negative child is very high. But the fact that we are at 8.6%, it shows that then these interventions are not at optimum level. First, they need to be on treatment. The babies also need to be put on ARVs when they are born. Then exclusive breastfeeding, then after that, children are weaned out. So I think this is an area where we feel we can focus on, support the HIV positive mothers, and ensure, because there is nothing as good as having a HIV negative child for anyone. The rates in the country, you find there are counties where the rates of mother-to-child transmission are very high. And I'll tell you, these are counties also where the issues of stigma are very high. So even a mother will not want to go get tested for HIV. And if she's tested and she receives her positive report, she will likely not disclose or take the ARVs because of the stigma from the community, from her husband, from her mother-in-law. And something he picked out or talked about is that, unlike what you may think, along the Lake region where the HIV prevalence is high, the stigma levels as a result of HIV are low. They kind of accepted it as a normal condition. They go for treatment. They know their siblings are HIV positive. But in other places, northeastern, you see the pastoral areas, still stigma is very high. And therefore, even these women, you'll find them, they are not going for treatment and interventions. That's why you find that Mandela, for instance, for HIV positive mothers, close to 40% of them transmit the infection to the baby. Then, why should we focus on young people? Because the triple threat is about young people. Quickly, I'll show where we are at. And this has been, the population of young people across the world has been increasing. Okay, not in developed countries, but in most of the developing countries, we know the population of adolescents has been going up. And for Kenya, these are the trends from 1979 to 2019 from the census data. And with the trends, all the numbers going up, it's need to focus on young people. But more than that, we asked young people questions about issues of HIV and sexual and reproductive health. These are survey we did, and some of the responses they gave us were, one, they don't have HIV, they don't have knowledge on HIV, yes, on issues of reproductive health, sexual and gender-based violence. Initially, when you know HIV was new in the 80s, late 80s, 90s, and even early 2000s, there was a lot of education, mass education, billboards, coverage, even by the media, the same thing that happened with COVID, isn't it? Every day in 2020, the news would be on COVID. You would cover that, or? Yes? The same case was with HIV. But now, with COVID, when the numbers dropped, the numbers of people getting COVID, dying, and when people started understanding about it, then even the reporting has come down. In fact, it's rare to find that reported. Same case for HIV. So with that, then we find the knowledge levels have also come down, especially more so amongst the young people. The older generation maybe can remember from what was there. Never mind, we are still using channels to ensure information is shared. Then the aspect of alcohol, substance abuse, and employment is also weighing down the young people. And as a result, to calm themselves down, they're engaging in sex, alcohol, especially as a result of unemployment, a lot of substance and drug abuse, which is fueling the triple threat. Boys, they say that, for the girls who are interviewed, they say that the boys are still the gatekeepers and make sexual and reproductive health decisions for the girls. This was very interesting. And what they said, the girls said, well, they might have all this information, but if their boyfriend tells them or they want to have sex with them somehow, and they like this boy very much, they want to experience. So if we don't engage boys as change agents, then we may not make progress in the HIV response. Then another aspect is on about parenting, and that still parents make decisions. Then peer pressure is also a key driver of the triple threat. We had data from the Kenya Demographic Health Survey, and it showed that the percentage of young people who had had sex before the age of 15, when the boys or the male was higher at 18% than females. Then the percentage of still young people, we are now putting a case wide focus on young people, 15 to 24, who had more than 2 partners in the last 12 months prior to the study, and reported using a condom during the last sexual intercourse. Here we are putting, what we are projecting is that 15 to 24 years, where do we find this age group? 15 to 24.
Was it?
They are either in high school, isn't it? College or universities, yes? And for them, they had more than 2 sexual partners in a span of 1 year. And they reported using a condom during the last sexual intercourse. You find that for females, it's lower, 35%. For male, it's 63%, showing also the gender dynamics on negotiating for safe sex and who decides on condom use. And more, you find that for the female, it's much lower. Then also, the young people were asked about able to see the heading, their sexual experience.
That I have less than 8 minutes for you.
Okay, so let me move faster than that. What motivated them to having sex, the first sexual intercourse? You find most of them say they were curious about it. And whether they used a pregnancy prevention method, most of them decided to prevent pregnancy, but they didn't use a method to prevent them from getting pregnant. Then later they were asked about the timing for the first sex, and most of them, apparently, those who said they were curious, they had sex, but now, later, they said they wish they had waited long after the curiosity ended. Why we talk so much about aspects of sex is because HIV infection is mostly transmitted through sexual contact and unprotected sex. So if we don't address issues of protection, then we will see aspects of increasing new HIV infections. Still from the data, that is the demographic health data, we find the percentage of knowledge of HIV prevention is also low among young people. And this is where now we need to put interventions with the schools, those outside the school, to ensure that they have information. Bringing in the aspect of adolescent pregnancies or teenage pregnancies, it was also established that those with no education had higher chances of getting pregnant at an earlier age than those with, for instance, post-secondary education. So that's also something to focus on, ensuring young people remain in school as much as possible. This is also amongst young people, the counties that had the highest rates of new HIV infections. Still, we find it translates also to the counties that had high aspects of prevalence. Quickly, I can talk about stigma and discrimination. With HIV being with us for the last 40 years, still aspects of stigma are very high and discrimination. And this is from the Kenya Demographic Health Survey that was done. And you find that, first of all, people are not even disclosing their status because of fear of rejection and stigma. And this shows the people who have disclosed their positive status to anyone, 81% women compared to 78% men. And then we have those who say they feel ashamed because of their HIV status, 38% women, more women feeling ashamed of their HIV status than the men, and that people spoke badly about them. These are some of the indicators that were tracked up on aspects of stigma and discrimination, showing that still 40 years after the first case of HIV infections, we are still dealing with aspects of stigma and discrimination, even after knowing how HIV is transmitted. Let me quickly go now to the Triple Threat Initiative. And for the Triple Threat Initiative, this is a multi-sectoral evidence-based initiative that adopts a whole government approach and community approach to deal with aspects of ending new HIV infections, adolescent pregnancies, sexual and gender-based violence, targeting adolescent girls and young women. Why we felt that this is important is because coming from an HIV perspective, we found that there is a close linkage or relationship between the three. That's why they are called triple threats. Mambo matatu: new HIV infections, adolescent pregnancies, and sexual and gender-based violence. And for instance, a case scenario, a girl is 15 years, yes? She engages in sex with a boy 17 years or even 16 years. She gets pregnant. What happens? She may not even get HIV from that sexual act. She gets pregnant. The likelihood is that she might drop out of school. Yeah? She needs to fend for this child. The easiest way to fend for this child is what? Sex work, isn't it? Because she's 16. Who will employ her? People will not want to give her a job. So the easiest way is through sex work to fend for herself and the child. And in the process of that, she gets HIV. She may get another baby. And we've seen that happening. So this triad of HIV infection, adolescent pregnancies, sexual and gender-based violence, or even we have seen girls who are violated, who are defiled by even a relative. Incest comes into play, and as a result, they get either HIV or they get pregnant, and the cycle continues. There are also girls who are HIV positive, yes, get HIV, get pregnant, and then sexual and gender-based violence. So that's why we are saying it's a multi-sectoral, bringing all stakeholders on board to deal with this, different government agencies, and also communities, so that we are able to address these new HIV infections of 62 new HIV infections in this age group of 10 to 19 that occurs in Kenya every week. And 23 deaths, most most of these deaths, are never reported as AIDS deaths. So the triple threat, an intricate relationship where sexual encounter can result in HIV infection or adolescent pregnancy, and we have said sometimes it's forced, it's defilement. So the aspect of sexual gender-based violence comes in. Then the pregnant girls can be married off, can drop out of school, and they are disempowered. When that happens, this girl gets even disempowered to make decisions. So for us, adolescent pregnancy is a proxy indicator of heightened HIV infection, because for that pregnancy to have happened, it shows unprotected sex happened with who we know or we may not know. The HIV status of these persons, we may know, not know. And we said for women or for girls, they are at a higher risk of getting HIV than the men. Then gender-based violence increases the risk of HIV because of the disempowerment that comes with it, and also the forceful act. Pregnancy among adolescent girls, it's associated with negative outcomes. For these now adolescent girls, we find that they are the ones, when they are pregnant, even seeking going to the health facility, to the clinic. They are likely not to go to the clinic because of also the stigma associated with that. A 15-year-old, who will even take you to the clinic unless you have maybe a parent who is supporting. So these are the guiding principles of the triple threat, leaving no one behind, working with everyone to address this, a multi-sectoral collaboration, engaging everyone, partners, and you today. We want you to be part of this story to address that aspect of HIV infections, adolescent pregnancy, sexual and gender-based violence, financing leadership in that, whereby somebody will actually speak for these young girls who don't have a voice, who have been disempowered, and then having a common objective to address this. So far, this initiative has been going on for like 2 years now. We've had a lot of media coverage. Thank you for that. We want to do more around this, create more stories around that. And some of the lessons we've learned are that use of local and vernacular languages mixed with Kiswahili. We're now talking to gatekeepers. And for gatekeepers, our target has also been to talk to either, let's say, the chiefs, the people who make decisions in a community, or where information is relayed. How do we engage them and ensure they are at the forefront of fighting this, so that if a case is reported, for instance, to a chief, that there is this girl who was defiled, this 13-year-old was defiled by the cousin who is 30 years and is from a rich family. The chief does not feel we can solve this at home, but they feel that it's their responsibility to address this. And this case first needs to be reported, the girl needs to go to hospital, yes, and she needs to get justice so that we can reduce the numbers. Then embracing different approaches, use of experts, dialogues, and songs, poetry, name it, whatever it is to share information, involving community leaders, and all communities. It does, now the triple threat, by the way, it does not respect culture, does not respect religion. All communities are affected. We are all in this. You will find it affects everyone, from the upper class to the lowest level. But also that's something, the stories mainly we have are from those in the lower levels, and how can we now see how it's addressed at among the middle class or upper class. The use of public places. This is an initiative or a campaign we want outside boardrooms. let it go to different places, address people where they are, for them to know they are responsible and they have a role to play. Use of national and local media to ensure people are reached with information on what they can do and that it's an issue. Daniel, okay, I'm about to finish. We are in the den together, remember? So let me finish this. So gaps and limitations. One, we don't have adequate programs dealing with the three. You may find that even as somebody was saying, the NGOs are there, some may be looking at aspects of HIV, others on gender-based violence, others on adolescent pregnancies, and we felt that it's important to have a program that is wholesome, looking at different aspects, including empowerment, so that when you address issues of HIV, you look at it wholesomely. What are the drivers? How do you address it? How do you ensure even girls remain in school? How do you ensure you address issues of drug and substance abuse amongst both girls and boys? Then limited involvement of boys and men as champions in the triple threat. It may be affecting girls, but we want men and boys to be champions. Let them address it, because who is responsible for the pregnancies? Yes, it's the boys and the men. Not all men and boys are responsible for these adolescent pregnancies. There are some very good ones, the fathers, the uncles, the brothers, and other community members. Let them now come up and fight this vice that is happening. Then limited social interventions addressing the causes, the economic vulnerabilities. What is making this girl, 15 years, sleep with this guy to get 100 shillings to buy sanitary pads? Or why are the girls maybe sleeping with other older men to get the money? How do we address that? Those social vulnerabilities, the social cultural norms around them, the religious and gender inequalities, marrying off of girls, yes, when they get pregnant. Then also we want them to be involved as change agents, the young people and adolescents themselves, and now reaching the young people in school. Reaching on leadership, we have various leaders. How do we address that? Now, opportunities that are there, we need to leverage on political, religious, community leaders, everyone. This is a campaign that draws everyone's heart, by the way, and I feel even for you here, you know about a girl who maybe dropped out of school or her life changed after she got pregnant when she was young, 14, 15 years. Initially, some or even today, they end up, doing menial jobs, yes, to survive. Yet maybe they were defiled. They had no one to speak for them. How do we become their voice? How do we fight for their rights? How do we prevent it from happening? Yes, because this now disempowers them. Then using the triple threat platform to address other aspects, drug and substance abuse, prevention of mother to child, mental health is also an issue, empowerment. Mentorship programs for young people, and more so, you find after they finish even fourth form, those who don't make it to go to college, universities, what happened to them, or their parents are not able to support them to attend tertiary institutions. So the media, use of the media to tell the stories, both the positive and the negative. I know maybe for some girls, they went through this, they've been able to overcome this, maybe they were able to go back to school, they got support, and now they come out as positive.
Sorry, Kara, to stop you.
This is the last slide. Untold stories for consideration. Yes, this is what I think we can open it up further. And we were thinking, we focus a lot on the girls, which is important because that story has to be told. The data has to be shared. But it would be interesting also to feature the boys and men responsible for these pregnancies. You may find some of them as ageless, Romeo and Juliet, isn't it? How has it impacted them emotionally? Has it impacted them or even affected them? Educationally, socially, it would be interesting to even interview them and know how their life has changed. I know mainly we focus on how the girls' lives has changed and maybe what drove them to this. I think it would be good to know that so that we know how to address and curb this. Then men and boys as agents to address the triple threat. I had talked about that. Positive stories about girls who faced triple threat and later excelled. There are those who it was not all doom, but there are those actually it has been all downward trend. We have girls who have actually come out of this strongly. Can they be champions? Can they tell their story of how they were able to address this and turn it positively? The aspect of incest. Incest is usually very hidden. More so because remember it's among family members. They don't want to talk about it, but it's driving the triple threat. Yes, who will be the voice of the victims of incest? When, where is it happening? How do we see it well in that? Then also cases of mentorship opportunities. So my request is, let's see how we can partner together so that we commit and account for every child. Thank you.
Yeah. Thank you, Carol. Is your name Caroline, Carol? Which one?
Caroline.
Oh, that? Right. Yeah. Now, Caroline said that she was not prepared for your stories, but at the end, she has given us some story hints, isn't it? Huh? Yeah. And then the way she talks, do you think that this lady is addressing the media for the first time? No. Do you think so? When you speak, she's talking about issues of sex, isn't it? And sex issues are very sexy, isn't it? True or false? True. Yeah, and by the way, everyone had the first time you had sex, it was out of university. Is there anybody who was just going there because it was a job? It's no? Are you speaking for yourself? Be careful. We are record. Now, thank you very much, Carol. I just want you to take a glass of water, and I want, please, I know you are bound to speak to this lady who has been talking about sex and condoms, but I know she's going to talk about surface area, but that is for another session. Now, I have a young lady who wants to talk about her experiences with the triple threat, and she knows that she's going to address the media. Elizabeth, it is your turn to speak to us. We request you just to stand there, introduce yourself, and just tell us about your experience on issues of triple threat, and most importantly, one of the slides that Carol showed us. How would you want us, the media, to report issues of the triple threat?
Okay.
And Carol, another thing, Carol and Elizabeth, we hope that you are comfortable with us recording. You're also comfortable with us taking pictures. You are also comfortable with us doing interviews after this. You are also comfortable having lunch with us, and you're comfortable with us. May I know if there's any discomfort that you have?
I think I don't. I'm cool.
You're cool, Great. Cool, Carol. Cool, Elizabeth. Take it off.
Good afternoon, everyone. Good afternoon once again. My comrade, my captain, again mentioned my names are Elizabeth Aquino. And like I mentioned previously that I work with an organization called Race Agenda.
And we work with women who have gone through sexual violence. But more specifically, we work with women who have gone through sexual violence in times of conflict. Today being a Friday, I did not carry my machine. I decided that nikitoka hapa, when I leave this place, being a Friday, you know what happens on Friday. So I am not going to do a presentation. You'll get along, I'm a very cool person. I really appreciate the professionalism of having slides around, but today I'm not that person. Sometimes I like doing my presentation freestyle, and I am very comfortable in doing freestyle because it comes from my heart. Asante sana. So I was asked, when I was coming here, I was asked to talk about the triple threat. It's not my first time sharing, doing a presentation with measure. I think this is the second time again, right? Right. Yeah, it is. So I am going to just go quickly through what I want to share. And let me start by, like I had mentioned previously, we work with women who have gone through sexual violence. Our organization is a survivor-led organization. When I talk about survivor-led organization, it means everyone from the founding director to the members of the organization, everyone in the organization, except maybe the partners, are people who are women and men who have gone through sexual violence. Race Agenda started as a response, as an organization as a response of the post-electioneering period, whereby, like everyone knows, I don't know if everyone is aware, there was a time here in Kenya went through a very bad conflict, internal conflict amongst us, and it was really bad. But in terms of response and recovery, the people who were being paid attention to were people who had lost their lands, property, or people who had lost their loved ones. Nobody was mentioning about women who had gone through sexual violence at that time. And that is how Breast Agenda was started to respond to the need of women who had gone through sexual violence at that time, including me myself. During the electioneering period, I was only 16. At that time, it was 2007, 31st December. I was going home from my cousin's place. I had left my cousin's place. I went to a friend's house, very excited to go home. Then the elections were announced. And I'm on my way home, and I met this crowd of men. It was around evening, headed for 6-7. And then I met with this gang of men, and they greet me in a language I could not understand. At that time, it was a certain tribe against a certain tribe. I don't want to mention that, but this is going to the media. And they greet me in a tribe I could not understand, and I'm like, definitely I couldn't answer back because I didn't understand. Or maybe if I understood, I didn't have the exact word to answer back. And then there was an argument, then another thing led to another, and all of a sudden I felt a very sharp pain at the back of my head. The next thing happened, I found myself naked on the riverbank, along the river, and I thought I was dreaming. I was in so much pain, and I thought I was dreaming. And so I laid my head was really in pain. So I laid my head back to go back to sleep, thinking that maybe it was a dream, or maybe a very bad nightmare. Unfortunately, it wasn't a dream. So that is how I was gang raped. And I did not report. I did not seek medical attention. And after that, after some time, I realized I was pregnant. So I am 16 pregnant, I'm an orphan, I was living with a cousin. People who didn't know what had happened to me. And there was too much pressure on me to like say, the whole family was like, who is the father of the baby? Nobody was asking me what happened to me. Nobody is interested to know what happened, what really happened. They were like, the father, who is the father? And this really made me feel so bad. I felt like nobody wanted to know what I'd gone through. Like my pain did not matter to them. So I ran away from home and I ended up in Madare slums. So I had to start surviving. So I'm 15 years old, not killed. I was just a child. All the years of my life I was just a child, and now that I'm here to fend for myself. And I'm in Madare, it's a place where I have never been before. I remember back in the days when I was very young, and we were watching the news with my dad, with my late dad. And then if there is a news on TV about a fire in Madare, I'd ask, like, how do houses burn? I didn't know, because we are living in a house made of concrete. I don't know, like, how can a house be on fire? I did not get that concept, okay? So I'm here in Madare, and at that time when I went to Madare, it's a slum, and the houses are made of iron sheets. There are no toilets. There are no street lights at that time. There are no roads. Like, I mean, this place I've never been before. Man, anyway, I had to survive. And I did. Then I thought to myself, I didn't want that life. And I thought, if I have to be free, then I have to get rid of this thing. And I shared my experience, not my experience, I just shared with a certain woman that I'm pregnant, but I want to get rid of this baby, I don't know what to do. And then she just told me, you can have an abortion. I was like, so I used to, when you're in school, or maybe when you're young, you hear about abortion, it's something very crazy. I feel it's something inhumane. It's an abortion. And she told me, okay, Sam, you decide, do you want it or not? But then again, when I go back and sit down, I'm like, no, abortion is what I need. Yeah, because I wanted to just go back to being a child. I just wanted to be a child. I just wanted to go back to school. I just wanted my old life back. I didn't want to be in this place, you know? So she tells me, I need 5,500 for the abortion. So I had to get a job. I'm in Madare, around number 10, I got a job in California. You can imagine that distance. Evening, morning, evening, morning, evening. And I'm only working for 1,500 shillings per month. And time is running out.
So California to number 10 is about how many kilometers? 3? 5?
It's, yeah, almost.
Yeah, especially when we are young, it's even longer.
Yeah, it is. And I'm like, time is, the clock is ticking. Time is not on my, time is not on my side. And I'm being told, if 4 months elapses, I cannot have the abortion.
So Elizabeth, what did you finally do?
I take this job, I start working, and then I decided that this money is not going to be enough. I happen to be a very quick person, and I get into system I observe into systems very quickly. That is my personality. I'm a Leo. So I'm an extrovert. So I get into system very quickly. I start doing other jobs. So I wake up very early in the morning. I go to where I work, do everything, then get to the next job. I started saving money. Then one day, I'm going to work and I see a crowd of people around. And I'm like, I'm curious, what is this crowd all about? So when I went there, I saw the fetus of 2 babies. I've never seen that before. Well, it it just broke me. And it did hit me so hard, imagining that I'm also about to do that. This baby is going to be a victim, just like those two that I saw. And then I had a change of mind. The long and the short, I had a baby. So this is I'm 17 now, right? What am I trying to say? To cut the long story short, because I want people to go for lunch early, is that having a baby at that age with no skill, with nothing, is not easy. Being a teenage mom, it's not easy at all.
Okay.
And being a teenage mom.
So my question to you is,
Yeah.
You work with a lot of teenage mothers,
Yeah.
and then what have you? From the time that you had your experience to date, what are some of the things that you've done that are different, and to ensure that one, the ladies, live positively for one, and then two, what are you?
Again, one.
How do you ensure that the ladies who get themselves in like the position that you got yourself in, live positively? How do you ensure that they recover? I know it is not one of the easiest things if you have never had that experience. And then number two, how generally are you handling the ladies so that we are talking about the SGBV issues and how they impact on HIV and AIDS. So then, how is your group? What is your group doing to ensure that HIV is kept at bay, or in terms of prevention, the prevention methods are taken up, but also ethically, and then how do you integrate them back into the society? So that would be my take in terms of asking your question. My friend Helen also has one question for you.
Can I respond to that?
It's just related to the same. Thank you very much. Your experience is quite moving, and I'm sorry for what you went through. I'm just curious. At what point did you get a turnaround to your life? Because usually that moment, your life turns around. I think that's important.
Okay. Yeah. Thank you very much for the question again, and Ellen. So, before I get to Agan's question, I was mentioning that being a teenage mom is not easy, and number one, you are someone who you don't even have an identity card, right? So you cannot be employed by anyone. You don't have a skill. So most of the things that these girls get into, like Caroline mentioned, is prostitution, which is a contributor to the figures that we've seen here. Let me start by what Helen has asked me. My turnaround came when I didn't share my experience for 6 years. I kept quiet, and for these 6 years, it was they were crazy years because I went through post-traumatic disorder. I got depressed. I tried taking my life away. I tried taking the life of the child that I had and kill the baby. I tried so many things. At one point, I even tried selling the baby to someone for 1,000 shillings. It was crazy. So this lady tells me, you are really making this baby suffer for what? Sell this baby. I've got someone who can buy the baby. And she asked me the price. And then I just told her, I thought about it, and I'm like, just give me 1,000 shillings, that's all. For a 2-year-old baby, and the transaction didn't go through, unfortunately, but it happened for good. Fortunately, yes, fortunately it didn't go through. And this baby was my outlet of pain. So I would look at her, the disappointments, the frustration, I will take it out on her. I really beat her so badly. One time I just took a pill and just strangled her so, and I didn't care. I became very heartless. I didn't care what was. She started throwing her hands up, and she's like begging for mercy, and I didn't care. Then I'm like, let me not do it. And then when I took the pillow off, she was really breathing so fast. She was trying to breathe, you know. At some point, I just got a razor, and every time she draw me, I'd cut her, you know. I was really depressed. At some point, I thought, this baby is innocent. At the end of the day, let me not take the baby out, let me take myself out. One day, I just took a piece of paper, I wrote my disappointments, my anger, my bitterness, everything on a note. And I thought to myself, do I use do I use poison? Do I have myself? And I thought, let me have myself. Poison is pain. So you can imagine, you want to die, but then again, you don't have to go through the pain. Huh? Then I just bought a rope. And I'm in the house, and I just told the girl, go and play. And she's like, Mama, okay, Sawa. When you finish, I know you come skip the rope with me, you know? So when she went out, I thought to myself, so she's got some faith in me, you know? And then I didn't do it. But even today, sometimes when I get very frustrated, I normally think of taking myself out because it's something that is always playing in my mind, you know? And I'm in this position with all this empowerment. So you imagine that girl down there in the grassroots with no empowerment. What would they do? If whatever I went through, maybe let's say 16 years ago, is still like it really hurts me up to date. And what about those girls? You know? And I remember in 2012, a friend of mine called me. That was the turning point. A friend of mine called me for a concert in town. We were headed for another election. And there is this activist here in Kenya, who's a journalist called Boniface Mwangi, and he had photos of the post-election period. And then when I saw the photos, the pictures just kept playing in my head, then I just passed out. And then for the first time, I shared my experience with someone I didn't know, types of Boniface Mwangi, and then I started the journey of recovering, and then that is when I started sharing my story. And then when I shared my story, I met with my director, who is also a survivor, and we started working together and working at race agenda. And through that, what I do is normally give my advice on how we can develop good policies in terms of prevention and protection. Because I believe prevention is better than cure. How do we prevent women and girls from going through all of this? How do we protect our women and girls not to go through what I went through? Then again, in case it happens, how do we respond to it in terms of response? That is what I do in my daily life. And I like doing it because it comes from my heart. So I've been asked a question by a girl. Let me respond to the question very quickly. How to help the women to live positively? Number one, I share with them my story. So many times I meet with women in the slums. I moved from the slum this year. And most of the time when I go back, they look at me and they're like, Liz, what's up? What's up? You got a job? And I'm like, no, I didn't get a job. I just believe in myself and I trust in God. And I tell them, you know, you can do this and you can do this and you don't have to do this. But there is only so much that someone can do. Not just talking, but how do we link these women to the right organizations that can help them now recover? Because to speak the truth, also helping them to recover is not that easy, because there is this one that maybe is in prostitution and you're here preaching to them to stop that and you're not giving an alternative. You're not helping anything, because when you leave that place, you've done your motivational speaking, you've done your presentation, then what? So what we normally do, we link them to organizations that have got economical empowerment programs, that can help them with trainings. There is an organization called Mathare Children Fund for Nairobi. It's in Mathare North. So these girls, they get enrolled there and they're given, they're asked to choose a skill they would like to be trained on. If it is salon, they get trained for a certain period of time. If it is tailoring, they go there, they're trained. If it is making bags and sewing stuff, you know, they are trained on that to get a livelihood. Because let me tell you something, triple threat is an outcome of poverty. Triple threat is an outcome of poverty. And I will tell you one reason why. A lot of these girls who have gone through the triple threat, it is because of lack, number one, maybe the parents are not financially stable. And I've lived in the slum for 15 years. And I know how it works. When our parents, and most of the parents again are single parents. And the single parents have. For instance, me, I got my child out of bed, right? I bring her single-handedly, right? I don't have a job. I don't care. So the child just moves around, and because that same woman is not empowered, she's not enlightened, she doesn't know what else do you expect to happen to that child. So the cycle goes and it repeats. Now it is pre-programmed, it becomes generational. The cycle goes and it repeats itself, and I've seen it. And I can tell you cases that I've seen with my own eyes. I came into my mother, there is this girl, she's given birth to a child who is a girl. That girl is a child, that child is a girl, as we speak, has got a child who is a girl as well.
Elizabeth, you don't feel so bad.
Let me just reply to your question, number 2. How do we, like, I think I've talked about it. How do we handle the women? Yeah, by also like referring them to organizations that can help them and give them skills. But one thing that I would like to really address here, and I think this is the right platform, the biggest gap that we are experiencing as a country in terms of the triple threat. Because Kenya has got very good policies. Kenya has got very good protocols, including the Maputo Protocol, women, peace and security. All these documents, we have ratified them. Then why are we having the numbers of the demographic report the other day? Why are those numbers there? Lack of information.
Thank you.
Lack of information, and I'm saying, General, just
stop you. I'll stop.
Let me say this, then I sit down. I don't know my friend now.
Can somebody give me a better mic?
Okay, when he's getting the mic. I'm saying this because I remember when I was sexually violated, if I had the information about the post-rep care, none of what happened to me, having the baby and everything, dropping out of school, living in slum, doing everything. It's a very long story. Whatever I went through, I could not have gone through if I had that information. So let us give information. Let it not just be in this room. How do we ensure that this information trickles down from here to down there? Thank you so much.
Yeah, thank you, Elizabeth, for that moving testimony. I'll just tell where I am, sorry. Distracted the cameras. Now, I want to open the floor for questions. I know you had many questions when Carol was speaking. Anybody want a question?
Yes.
No? Okay, so Agatha number 1, and then Kelvin number 2.
And mine is a comment number 3.
Yeah, but I hope it's not a presentation.
Huh? Oh, no, it's not.
It's just a comment. Huh?
Yeah.
Okay, thank you. So your comment is number 3 stroke presentation. Then yours is number 4. Can I take those 4 very fast? Then I take the next round. Achimwani, I'll come to you later on after I've spoken to the Achimwanes.
Mine is very brief. Thank you so much for sharing your experience and I'm really sorry for what happened. And I'm glad that
No sympathies, please.
you're doing well. So my question is, how are you able to reach out to girls that go through the same thing that you went through there? How are you able to reach out to those girls?
Thank you. Just meet the lady next to you, Amai. You know, she's all the way from Nyasaland.
My question is to Carol. Maybe you can also ask Carol.
Yes, yes.
Okay, I was so much.
Carol, are you saying the person asking you a question?
Hi, Carol.
Okay, let's just stand there, please, so that you see.
Stand,
Yeah, you've been hiding, you know.
and introduce yourself.
Please, in the interest of time.
Come on, stand, Winnie, stand. Yeah, and introduce yourself as a public health specialist and you're interested in these issues. Never. There's a market here also.
Okay, Carol, my question is, I have two questions actually. The first one is, do you have test and treat here in Kenya? If it's happening, have you noticed any significant maybe impact when it comes to prevalence versus incidence with HIV? I really would love to appreciate that because I think in Malawi it has had quite a good impact, especially on incidence. And again, on the PMTCT, if I'm not mistaken, I saw something like 3.8%. This 40% at a place called Mandela.
Yes.
You mentioned issues to do with stigma and discrimination. I think that maybe affects adherence to therapy and all that, but I just wanted to know what measures are you putting in place because those are quite scary figures. The percentage is quite high. Just wanted to appreciate what you have put in place for you to address this. Thank you.
Thank you. Who's the next, Kevin?
Okay. Yeah, my name is Kevin Omolo. Hello?
Go on.
Hello?
Go on.
Yeah. I think I'm.
Can you tell the hotel you give us better mic quickly?
Yeah, I say I'm Kevin Omolo. I happen to come from Kisumu, one of the areas which are having very crazy statistics. But my question is, in terms of intervention, if you could share data, especially on how much the government is investing in fight against some of these scourge, so that we can see, is that commensurate to the figures that we are seeing here? Because we've had instances where we report that there is hunger in this area, but we invest a lot of money in that another area which is not having such figures. And lastly, any strategies that you have in telling some of these stories, because that was a concern that the way we tell some of these stories, especially like he mentioned sense of fish, that the way we tell them is not bringing out a solution, you know. So as an organization, arm of government, do you have any strategies of how you have or you want the stories told?
Okay, Suzio. Thank you so much for the presentation. The last one in particular, but maybe just a word of encouragement that I think at your level you should be giving more of a message of hope, and not really where you say even at the level where I am, I still think about committing, because eventually somebody listening from you would getting the inspiration to really think, you know, as empowered as you are, you can easily be defeated by the thought of, you know, suicide. So I thought I could encourage you on that. Thank you.
Yeah, I mean, the expression of vulnerability, because we think you're already a champion, you overcome it. So, you know, I'll see you. But I also think that in terms of that, as it were, it is all about, you know, the various cases that you handle every day and the various situations that you undergo every day. But again, I know a little comment about you on the dynamics will come later on at the time when you'll be answering the question. Just a minute, this lady, her hand was half, then you.
Yes, my question is to Carlo. So I saw on the charts that we, the youth from age 15 to 24, we had the higher percentage in the HIV infection. And I also saw on another slide that you say there's HIV percentage for men to men. But now on our generation, we have this homosexuality that is being passed or being tried to pass. And this is something that is emerging among us. So my question is, are there any awareness being created among the women to women? Because they didn't see any chat there, maybe probably because it was not there. But you see now it's emerging. So my question is, are there any awareness or measures being created to protect women to women who are engaging in women to women sexual, so to prevent the HIV?
Yeah, so basically, I think we are talking about key populations as well. And maybe you can just make a statement on that. It's just
looking at the health being a global function, and this budget seems to be counted as also. How are you able to convince this process to invest more into combating or trying to fight HIV? Secondly, to Elizabeth, now that you have a children daughter and you said that this to be tightly, what steps are you taking to protect them?
yeah, and Carol, I think to just add something on Justice's question is that do we have evidence to, a case study of where the county government is actually putting some more investment on issues of prevention? I think that basically is it. There was also one hand here that basically means there will be no more questions after being said. Oh, then, yeah, so that then this table then.
Thank you very much. I remain Vincent in Nigeria. I don't know if you have specific studies that look at secondary school system, because secondary school system, because a lot of things happen at the secondary school level, because especially the boarding schools where these young adults, they go, and then sometimes during the break, it takes 3-4 days before they get home and they start getting medicines. Sometimes they have work. So what is the prevalence rate at both secondary school? I'm not talking about the university, because that's a big one. But I'm thinking that we help parents also make good decisions.
Thank you, Vincent.
And my second question today is speaker is
Elizabeth,
yes. You've gone through this very traumatic situation, and then you have a daughter. How do you deal with the fact that she might one day ask you who is her dad, and then how prepared are you to talk to her about perhaps the stereotype she's likely to face in the society? Now that you're sharing your story, and people get to know that she's associated with you. Thank you.
My question comes to you. I appreciate that you talked about stigma and discrimination. Later is take out quite a bit. So I was wondering if you mentioned anything with self-stigma and discrimination, because from my conversation with HIV advocates, they seem to say that the issue of stigma may be going down on the society which accepting it. There's an increase in self-stigma and discrimination. And in this case, I want to speak on teenage mothers and young women living with HIV. I was wondering if NSDCC has an insight on this demographic, especially looking at the issue of sexual and reproductive rights, and what are some of the systematic challenges that contribute to this issue? Thank you.
Wow. I usually tell our members that a story that is not told is a life that is lost. So when we attend these meetings, let us tell a story. Listening to what everybody is saying and what Elizabeth said in her parting shot is that the greatest or the weakest link is information discrimination. Up to you, but I want to appeal to the two of you to resist the temptation of making another presentation. Yes, you answer those questions. Can you be very brief to the point? And somehow, if you like, you can be vague so that the journalists can have time to talk to you. Can we attempt?
So, can I go first? Thank you, my senior. Thank you so much. Okay, so let me go very quickly. Let me start by appreciating your encouragement.
Naitwa Suzio Chitete from Malawi.
Suzio, thank you so much for the encouragement. But let me just also say, it is very okay to be vulnerable. You know, that thing of being this very strong person is the reason as to why people are committing suicide. So if I come here and I'm talking about how vulnerable I feel sometimes, it's because I feel I'm in a very good space. I'm in a very safe space. And I can tell all of you, it is very okay to be vulnerable at some time, but don't accept defeat. I feel very vulnerable at times, and one thing I know, I have never accepted defeat, and that is why I'm here. I've been asked, how do I reach out to women? Yes, we do a lot of radio sessions. We normally have this period where we do a lot of radio sessions during the 16 days of activism. How many people are aware of it? 16 days of activism against sexual violence. It's a period whereby we work from 25th of November to 10th of December. We are talking matters of prevention, protection, and response in terms of sexual violence in any setup. And during this period, sometimes we normally get fundings and we go to radio stations, and I normally share my story, and after sharing my story, we give women hope. I share my number, I share my director sometimes shares my number. We go with people from government, from the police, from the courts, everybody who is a stakeholder in terms of response for sexual violence. And when that is police, court, safe spaces, people who are in safe houses, we normally go with them. We give the number 1195 to call in case there is a case of sexual violence or domestic violence. That is how we've been able to connect with these women, and they can call me at any time. Okay. Another question is, what steps am I taking to protect my teenage daughter? And I think I'll answer that question with what you asked me about how am I handling my daughter with everything that I've gone through. This year, there was an organization that invited me and my director to present our stories, because it is called Doc2Box, whereby you share your story and it is used as a documentary or a short video clip to give information to other people or to strengthen other people. And this year, I did call it quits in my marriage, because another thing that women who have gone through sexual violence have realized, when they get married, the other party tends to use whatever these women have gone through as a weapon. And the man will tell you, went through sexual violence, so can get married to him. Matter of fact, I'm doing you a favor. And I told the man, wait and see. Okay, so I left. I took my children with me, and I thought it was time, because my daughter was really going through a very difficult time, you know. And at some point, she even tried committing suicide in school. I had to take her out of the boarding school, stayed with her for 2 months at home for her recovery. And I thought, now, that period, I thought it was the proper time for me to use it to disclose to her what happened to her. Because that guy is gone, because she's been staying with this man, and she knew that guy was the father until that man did the unbearable. He tried to kill me in front of my children, and this was too much for them. So when we went for this documentary, I tagged my daughter along, and I told her, I've got something that I want to disclose to her. So in that time, there were 3 chairs like this, and I went with my director because there is a link in my story and her, and my victory story is linked to her because she's the one who found me, talked to me, and held my hands and working with me. Then I shared my story while Brooklyn was there. And she really cried bitterly, and she said she wanted to understand why I treated her the way I did. As much as she was a child, she still recalls, she still remembers, she still has got the scar. She sees them every day. So she cried and told me, I wanted to understand why you did that to me. And this has really been bothering so much. And she said one of the reasons as to why she tried to commit suicide was because she thought of how I mistreated her back then. And she linked it to what my ex-husband did to me. And she thought there was no hope, you know? So at that time I disclosed to her, we went through some counseling session, but I thought now the ball was in my court. It was up to me to do what I had to do best. To let her know she's my very good friend, she's my daughter, she's my love, and I really love her, okay? So that one I did. I'm still working it out, but I must tell you, building trust is not easy. When it is broken, it is not easy. And that is what a lot of these girls are also going through. So one of the things that we encourage the women to do is to love the children. As much as what happened, it is not the fault of the children. But at the same time, one of the things that we are really advocating for, and I don't know if you'll agree with me or not agree with me, but whichever one I'll just say it, is access to contraception. Access to safe abortion. I think it is time that we can open ourselves to this discussion, because the rate at which our children, our girls are dropping out of school because of teenage pregnancies is alarming, and very soon we will have no women in this country like Martha Karua and Wangari Maathai anymore. All of them will have dropped out of school. You know, it is happening and we are just quiet, we are looking at it, we think it's a joke, it's no joke, it's no play. It is really disturbing. Such things should not be happening in this era. So I think we've got so much to do. Thank you so much.
Okay, allow me to respond to the questions too, and thank Elizabeth for putting perspective into my presentation. You are able to verbalize it, and I guess now they're able to see what actually true perspective is. Thank you so much for that. So going straight to the questions and ensuring I don't start another presentation, on the aspect of test and treat, we have that in Kenya, and it has actually led to the decrease of new HIV infections. Incidence rates have come down. You'll find from 2010, the data I presented, to 2022, the incidence rates have been coming down. And also, it has led to more people starting the ART program immediately. And what also that has led to is that the infection rates have come down because the viral load is suppressed. So it's a program that we are running and it's working for us. We hope that it can now be at 100%. Then the aspect of Mandela, you're able to capture it well, 38% mother-to-child transmission rate. Let me put it into perspective. Mandela is out the northeast of Kenya, and their stigma levels are very high. Culture also plays a key role. It's a dominant Muslim community county, and you find that the rates of mother-to-child transmission rates are high, are the highest in the country. So you ask about, are we doing anything about it? Yes. But the fact that we even have this data to show there's a problem is the first thing. Then we have programs specifically for addressing mother-to-child transmission rates. because you find that the new HIV infections are low for the general population, but high for mother-child transmission. So we are engaging community health practitioners, mentor mothers who are now working or mentoring the women who turn HIV positive once they are tested, to see how they can work with them to ensure they start treatment and also enroll their children to treatment. So there are programs at community level and even with NGOs, CBOs, but also government-specific programs engaging community gatekeepers. Then the aspect of government supporting the HIV program in the Nyanza region, not just Kisumu, but the Nyanza region and all counties. I'll start by saying that one, I think amongst all diseases and ailments, still ARVs are provided at no cost in government facilities. And we rarely have shortages. In fact, when they are there, we know, because they are not cry around that. So that's the fact that ensuring that everyone who is HIV positive is able to get ARVs and on time. Testing is also available at no cost. It doesn't matter where. In fact, where we have challenges is like maybe in the northeastern region, where the government facilities are far apart. But where we have many government facilities, most of them provide these services at no cost. Provision of condoms is also provided not just at the universities, but in other institutions and health facilities, and provision of even pre-exposure prophylaxis and post-exposure prophylaxis for people who get exposed to HIV or the pre-before. So yes, there is a lot of investment from the government and from donors. And I guess it might be among the few programs that are actually people are not paying for treatment. In addition, of course, to TB drugs and all that. Then there was a story about how do we tell the story, or how do you tell the story? And one is that provision of correct information. I shared the data here. I believe it will be available to you so that as you write your stories, you can put the correct data and information. That's the first step. Because if it's bent wrong, everyone who knows about it discredits it. Yes? Then for aspects that are not clear, it will be nice also to do a little bit of more research. Some of the things maybe were shared here, personal or perceptions. Perceptions may be different for different people. So by doing more research, getting more information, then it's possible to actually report on the correct data and capture a story that is in sync with what is happening. About the key population and aspect about men who have sex with men, I know you asked about that, and also women who have sex with women. For the key population, for us, we provide services to everyone who requires them. It does not matter whether you are a sex worker, you are a man having sex with a man, or you are a woman having sex with a woman. When you go to the health facility, you get whether it's testing, treatment services, or STIs, or HIV. There is no discrimination. Because as we say, these are the people still interacting and moving with the general population. Yes? So their programs are there. I know there are also NGOs coming up specifically to address the different key population groups to ensure they get a wholesome program. But for government, it's provision of the services required. Then about counties and devolution, knowing that health and HIV is a devolved function, and whether counties are investing more. We need them to invest more because unfortunately for the HIV program, it's heavily donor funded. Yes, you find even for ARVs, for test kits, for condoms, still we get a lot from the donors. The donors are reducing all their funding because there are new problems coming up, and I guess maybe you even addressed them. There's climate change, there's famine, there are all these other issues. So the need to invest more, this is the time. Not to wait for now when the donors fully go and we start asking ourselves how we provide ARVs. And investment is in various programs, not just for treatment or the drugs, but prevention, so that we don't get more people getting into the pool who will require now treatment for long, because that way then it means you have to put in more resources to address that. So there's still a gap. There's need to invest more to prepare ourselves adequately. I know some counties are doing that through the county investment development plans. They have plans on how they continue supporting the program, the HIV program, the triple threat, but there's room for improvement on that. Studies focusing on secondary school levels and adolescents and young people. Let me start by saying, first of all, even for the triple threat campaign, the age group we are targeting is 10 to 19. You find that these are children who are either in primary school or secondary school, a few of them in tertiary or universities. When we share our data, even from the Kenya Demographic Health Survey, we have data clustered into groups 10 to 14, those are mainly in primary school, 15 to 19, those are in high school. So that data actually will give you information about that cohort, the high school students, the secondary school students. The question is, how can we unpack it, disseminate it to different groups, including parents, for them to understand that it's not just numbers. You know, sometimes when you say 10 to 19, you don't remember. By the way, my daughter is in 42. And what they are saying is that for her, the probability of getting HIV is higher than my other daughter or my son, who is 30 years white. So I hear you, that's room to unpack the data more, make sense to different groups and different meanings, and not just share it as is. So there is room for that. We have the information, it's the sharing that we need to improve on. The issue of self-stigma and stigma, I shared about stigma and what people felt, and we have the two. We have the self-stigma and also the general stigma by other people and discrimination. It's still there. It hasn't gone down, especially in some cohorts and some groups, and I showed that. For self-stigma, it's also as a result of what will people say if they know that if I come and tell you I'm HIV positive, I get scared and I'm like, you will start judging me. How did I get into sleep with? And unfortunately, sex, HIV is a lot connected to sex. And with that, we are still, issues of sex are still taken to be controlled, that there is a way it should be done, and that people take it that, oh, then this person maybe is promiscuous. So it's still there. It requires information and acceptance, people knowing that or not addressing it based on how did you get HIV. It's about, you have HIV, you are a normal human being, you are my friend. We can still carry on with life without taking into consideration how you got it.
Madam Caro, I want to stop you there. I know you still have other questions you will not answer. But I have a group that is going to the airport and their car is waiting and they will not eat there. So I would ask them to just walk out, go and take dinner, lunch very fast. I'm told also dinner. Dinner starts from 12. That's the new English, check you out. So, please, the team that is leaving at 2:30, please just walk out because these Kenyans are staying here. Carol, how many minutes do you need to answer this? Go ahead.
So for young mothers, for adolescent girls, it's even higher. Because the society expectation is that you should not be having sex at 15. That's what people expect, isn't it? So if now you are here, you are not HIV positive, you get HIV positive, you get pregnant, already you feel you are being judged. So by embracing this, that yes, it has happened, but work with these girls. They have a story. Elizabeth has shared her story today, but it has taken years. Yes, working with them, trying to show it's still okay. You can still excel in this life, and documenting stories, success stories. After the scars, what has happened, and it will encourage most of the other girls who are maybe going through that and who are not, have not come out, have not been empowered. And it's the only true empowerment that will be able to address issues of stigma and discrimination. Lastly, we'll be marking World AIDS Day on 1st December. This is a global event, and we'll have activities running 2 weeks or 1 week in all the counties. So I request you to partner with us, join us, share your stories, document, and see what we are doing. It's the same period that we'll also be having the 16 days of activism, starting from 25th November, 10th November, World AIDS Day on 1st December. Asante sana.
Yeah, thank you very much. I think let us end it there. Issues of HIV never end, issues of sex, and I wish I brought it after lunch. Now, ladies and gentlemen, we invite you for lunch. The coupons, I guess they're somewhere. Let's have lunch very fast. To our friends who are leaving to go back to their countries, I think the 3 of you, please have the safest and the smoothest of flights. And respect what the captain there tells you. Now that my captaincy is not going to hold anymore, go ahead and please remember us and keep in touch. Carol, thank you very much for your bravery. You are doing it for the first time. You are a superstar. Thank you very much. Elizabeth,
Yes.
Keep on doing it. We are here for you, and we always want to work with you. Now, I invite you again after lunch for a very juicy afternoon of about 1 hour, where we're going to look at is our country really prepared for pandemic X? It's going to be a very short session because I know another team is leaving for other places, and we are going to have someone from Cambridge speak to us, and we're also going to have somebody from the Kenya Medical Practitioners Dentists Union talking to us. So 2 gentlemen are here in the